Good afternoon, ladies and gentlemen. My name is Stefan Verheye from Belgium, and I have the pleasure to co-chair this session with Dr. Waksman from Washington. This session is about the Magmaris Magnesium scaffold in a class of its own, the introduction to the Magmaris. The learning objectives of today's sessions is to learn how the Magmaris affects neoatherosclerosis. Secondly, to understand the optimal indications, the implantation technique, and the patient selection for the Magmaris. And to review new clinical data from the BIOSOLVE-II and the BIOSOLVE-IV trials. It is also my pleasure to share this meeting with an esteemed panel, and we will hear Professor Waynes talking as to why we need scaffolds. Dr. Joner will talk about reducing the risk of neoatherosclerosis, not only stent thrombosis. Professor Houde will share the experience in a case in a box from his center in Neuss. And Dr. Lee will give the new clinical insights from the BIOSOLVE-IV registry. And then finally, Dr. Waksman will conclude and share his key learnings and takeaways. In the meantime, you will have the time to ask questions, which we will try to address with the panel. So in terms of the Magmaris, there's a couple of key features that I would like to share before we talk about the talk about the device. First of all, there's compelling safety data. This has been published in CRM. There is data that the device has a good deliverability and performs in a better way than polymeric scaffolds. And very important is talking about bioresorption, as we have known from other devices that this may be associated with some problems. So in this case, 95% of the magnesium is resorbed at 12 months. This is just a technical overview. I'm not going to go into detail discussing each of the devices, but I think what is important is that the scaffolding time for the Magmaris is up to 3 months with a resorption time of about 1 year. It comes in 6 different sizes, and you see the diameter and the length. It has a tantalum marker at the edges, and the strut width and strut thickness is 150 micron, with a crossing profile of 1.5. And sirolimus is the drug that is coated with the BioLute coating. What is important also, and you will hear about this several times in today's session, is the 4 Ps. Patient and lesion selection, proper scaffold sizing, pre-dilatation for lesion preparation, and post-dilatation. And without any further ado, I would like to invite Professor Waynes to talk about why do we need scaffolds.
Thank you very much, Stefan. Thank you for the kind introduction, and it's my pleasure to join this symposium for actually the 3rd time in a row, and thank you for joining. I would like just to start again from, white page, and why do we need scaffolds? And of course, there's a question mark, but certainly I do share the conviction or the opinion that we do need scaffolds. These are my conflicts and relations of interest. Now, of course, you may think this is a funny slide, but it shows the evolution of devices from the balloon angioplasty to scaffolds. And it's presented as a Darwinian evolution. Now, what do we mean to say with this? It's just a matter of time. Sometimes we think that it should happen overnight. Nothing happens overnight, yeah? And particularly here, if you look at the evolution of the devices, it's actually pretty fast. So it's actually normal that in the cycle of development of a new device, and this is not just an iteration, it's a novel device, it takes time to reach the goal. Now, what is the goal? The goal is still vascular restoration therapy. And this is not achieved with durable metallic stents. What are the components of vascular restoration therapy? Support, very important. The acute procedure, support we need, resorption, and then restoration. So each of these elements we will discuss specifically, very briefly. Support, what we would really like is a metallic scaffold that would have a performance that mimics that of a best-in-class DES. The resorption, of course, is important because not only does the implant absorb or resorb, but the vessel also becomes uncaged. And this is a condition sine qua non to move to restoration, whereby the structure allows then a natural vessel response. So where do we stand today in the evolutionary development of the Magmaris? From these three perspectives, and I'll start with the support. I think if you've used it, you know that there is good deliverability of this device, and actually this can be tested in vitro. You have on the graph on the right the force that it takes to advance it in through models, the pushability that it can afford. Pushability, the higher the better with this metric. And you see that it compares to one stent here, BioFreedom, that has the same thickness as the Magmaris. If you compare it even to Orsiro, best-in-class metallic DES, you see that Magmaris, in terms of its performance, technical performance during the procedure, acute procedure, compares well to Orsiro. One of the problems with the scaffolds has been lots of recoil, and in fact here this can be nicely measured. And you see here from left to right, Magmaris, Orsiro, Xion synergy. Acute recoil is about the same. So we have already a number of key characteristics of the Magmaris, deliverability and acute recoil, that are comparable to a best-in-class metallic DES such as the Orsiro. So good progress is being made there. Now, what about the resorption? As was alluded to by Stefan, it is much faster than with some of the polymeric devices, and there is actually good preclinical and clinical evidence of good progression of the resorption process. And the OCT images there on the right are showing this from baseline 6 months, 12 months, 36 months. So first of all, if you look at the baseline implantation, it really looks like a metallic stent. It is a metallic stent, so no boxes here. You have the shadowing behind the metallic struts. And then at 6 months already, you start to see some movement there with partial change in the images, and around 12 months, it is nearly gone. So this is important in terms of the timing of the bioresorption process that completes as soon as the changes occur. Also, as was mentioned by Dr. Verheye, it is the moment where the resorption is nearly final that we need to be very careful for potential and expected side effects, and we'll come back to that later. Now, restoration. We have here two aspects, and this is more like a teaser for the presentation by Michael Joner, who will really show the data that support the contention here. Amazing data. First of all, it's a low thrombogenic milieu. As you may recall, if you attended previous meetings, the material in itself has some or low thrombogenic propensity. And here, shown from an animal model, a shunt model, where you're trying to see how severe is the propensity for the implanted device to actually cause thrombus formation. So anything red is bad in this case because it is thrombus. You see by yourself, I mean, the image is an illustrative image of what was shown in the model, from Magmaris down to stainless steel DES. Clearly, the Magmaris is a device that has a very low thrombogenic propensity. And the other key point in terms of the later restoration is the fact that we want to eliminate as much as possible neoatherosclerosis, and just some of the data will be shown in detail here. The study is interesting because a stainless steel DES here is compared with Magmaris. Macrophage infiltration is shown in brown, and there is significant reduction of neoatherosclerosis formation there with the Magmaris device. Now, clinical results. So we're on our way and making progress clearly in a number of key elements, components of the device. The translation into clinical data is here, and what's actually new is the data at 36 months. So you have target lesion failure, 12, 24, 36 months on the left part. Look at Magmaris from on the left, science in the middle, and synergy on the right part of the slide. So these are data from comparable populations and published here. So it's pooled data with the metallic DES devices. And the numbers are just, if you look at it from expected performance metrics, you certainly are in the ballpark and pretty close to what can be obtained clinically with a best-in-class DES. Safety on the right part of the slide, 12 months, 24 months, 36 months, very low stent thrombosis rates. Now, people sometimes say, yeah, but it's A, low number, B, it's from the studies. Yes, of course. And when you're developing these devices, you have to evaluate them and use them in a protected environment. You can't just use them for any indication. And in this slide is a summary of the table that was prepared by an expert group experienced in the use of this device with, Michael who's here, Michael Joner, and Ron Waksman, and Michael Lee. The three Michaels, like we said earlier. Yeah. And Ron, of course, is co-author of this as well. And it's a traffic light summary, red, don't go, green, fine, orange, be careful. Very easy way to help the colleagues to identify whether this patient or this lesion, patient on the left, lesion on the right, should be treated or could be treated with good success with the Magmaris device. And you see there is quite some red at the moment. And if you would look at all the data and incorporate, you will see some stent thrombosis. But if you analyze the cases, then you will find out that it was red all over the place. So the technology is evolving, it's improving, but it needs to be used with caution for appropriate patient characteristics and appropriate lesion characteristics. So I'll close here. Or almost 95% of the magnesium is resorbed at 12 months. That's a key element of the device here, and it's shown again with the OCT images. And we talked about evolution, and here it is. So we have in the middle the current version of the magnesium stent scaffold, and on the right the next one. And this is brand new information that will be discussed later as well. So the DREAMS 3G is going to be the next evolutionary step in this technology. More sizes will be available. We're certainly very happy to have larger stents up to 4.0. 2.5 will be available as well, although this will probably be orange in the first place. Let's be careful with small vessels. You'll have more lengths available for clinical use, up to 30 millimeters, so avoiding the need to overlap or abut two Magmaris devices. The marker is different. I actually don't know exactly what it is. It's not tantalum or some other, but maybe other members of the panel know exactly what it's going to be. Not sure it's relevant, or that important, but at least there's a new concept there. What is key is the strut thickness, so it's going to be 99 microns, at least for all the smaller up to 3.5. We still have the BioLute coating. Crossing profile was mentioned 1.5. Well, except for the 4.0, which is 1.5, we will have crossing profiles as low as 1.3 with the 2.5 device. Radial strength is improved. Recoil is similar, it's not increased with the thinner struts. The scaffolding time will be about the same, and the resorption period is also around 12 months. So important news, and I guess we can discuss later on the timelines for the development and clinical first-in-man implementation of this next generation Magmaris device called DREAMS 3G. So in summary, the scaffolds were originally developed to face the limitations of drug-eluting stents. Holy Grail is the same, but it's not just a word. Vascular restoration therapy is the goal in this age of multiple implants. Magmaris satisfies the 3 pillars of the vascular restoration therapy: support, resorb, and restore. Optimal clinical results are associated with optimal implantation technique, the 4P, plus proper case selection. And the next generation of magnesium scaffolds is currently in development. Thank you.
Thank you, William. I'd like to remind everyone that if you have a question on your app, we are in Theater Blue. You can post a question or a comment, and we will use that as a topic for discussion. I may want to to ask you one question which I'm struggling with about the superiority. So obviously at some point we'll have to do a randomized trial, and the randomized trial historically was a non-inferiority trial when we looked on the absorb. So when we would be ready, what would be the time that you think that we would be able to see an advantage of a scaffold over a metallic stent? How long do we have to wait to demonstrate this? Or we don't need to do it at all. I mean, we may say that you'll build it just on vasoreactivity or other parameters.
Yeah, of course, it is a critical question in this era where, you know, it takes courage and persistence to actually continue to develop these devices. So there is you have to have a strong conviction that it is an added value, which I certainly do, and many of you as well. Now, I'm very keen on having outstanding acute performance results. And I think that's very important. In terms of showing superiority or non-inferiority, you know, today we accept a new metallic DES if it's non-inferior to the best in class, so the accepted ones. Why would we do anything different here? Except that we know that in the longer term there might be a bonus. Neoatherosclerosis reduction, for instance. Fewer late failures. So a non-inferiority in terms of safety and clinical efficacy results that are within the range of OPCs, or expected, what do you say exactly, or expected performance characteristics is probably the way to go. And of course, I don't know how regulatory people would see this.
Yeah, I mean, it's a very interesting approach. Why do we need to see superiority? Any new stent that we bring to the market, exactly. We don't see it. Yeah. There is only one caveat, that if you want to charge more, you have to show the adding values. So that is the question. Do you need to show it on clinical outcome, or it could be enough on patient perspective or preference? If you have the two devices and they act exactly the same, and one is, I want this stent, is that good enough, or you need to show superiority? Or you may not need to show it at all. Michael Howday, do you have any?
I think the story is in this way quite simple. Once you start thinking about something new, you have at least to show that it is at its best superior in order to find your way into the market. If you are non-inferior only, you can mess yourself with the existing devices. And since we are all dealing with a health economical environment, it is very difficult to charge more money for something which is non-inferior to existing health. So you need to show something superior in order to ask for more reimbursement.
Well, that's a moving target, right? Yep. In Germany, it must not be very difficult to, to ask for a premium compared to the current price of a metallic DES. I mean, they're so low.
Yeah, I will tell you from my own experience, as you know, we still do brachytherapy in the US, so I get horrendous in-stent restenosis of metallic stents. And every time I see that, I said, this is my motivation to see as less as possible of those in-stent restenosis. And they don't do well with any technology, not drug-coated balloon or not another DS. So I'm not saying we're not going to see restenosis with scaffolds, but at least the first go-around, it's easier to treat them. But obviously, you would reduce the amount of the totality of in-stent restenosis. Again, you cannot measure it in studies metrics, but it's conceptually an adding value.
Thank you.
Ron, we have a question from number 2.
Thank you very much. So you told about the vascular restoration, and my question is a little provocative and maybe philosophical. Well, we know that the scaffolds, the polylectid-based scaffolds, showed adverse events even after 2 years, and the concept of the Magmaris is that after 12 months you should declare that it almost resolved. But about the vascular restoration, when you can declare that you get the restored vessel.
Yeah, I guess it is in 2 phases. There is already some restoration of vasomotion at the early time of dismantling, when the scaffold starts to so-called dismantle, so that some continuity is, and then later on when it disappears completely, I guess you talk about restoration, but that's I guess a functional definition.
Okay. Well, when you get adverse events that is connected with this lesion, from what time point you should declare that it is the new vessel, and the adverse events are not connected with the scaffold and with the restored vessel? It is a philosophical approach, not?
Yeah, so if I understand your question, you're asking at what time can you declare that it's gone and that the vessel is restored? Yeah. Yeah, I guess this has to do with the definition of vessel restoration, how you measure it, whether it's vasomotion or ability to either constrict or expand. But I don't know whether there is actually a formal regulatory definition of that. But I would suspect that when 95 or 99% of the implant has disappeared, you can start talking about a vessel that is back to its naive condition, but without the lesion, obviously. Yeah.
Thank you, William. This is as much as we can answer to this question. We do also have a question from React, but we need to move forward. So we're going to leave the question on the screen, and we'll come back to the answer of that in a moment. The next presentation would be by Michael Joyner, who did a lot of the preclinical work, and he's going to discuss about Magmaris-reduced neoatherosclerosis, not just stent or scaffold thrombosis.
Thank you very much, faculty, ladies and gentlemen, friends, colleagues. It's a pleasure. So I'm one of the Michaels. I will start introducing you in some translational aspects. I don't think I have to show this slide for very long, because you're, just as I am, well aware of the fact that there have been issues with first-generation scaffolds with regards to scaffold thrombosis, both early and late, but we learned actually that there is a substantial difference between early and late scaffold thrombosis, and also the mechanisms are different. So acute thrombogenicity plays an important role, especially for acute and subacute scaffold thrombosis, because you know stent struts are much thicker in these scaffolds, there's more turbulence, unphysiologic flow, and you can directly compare this, and William has alluded to this already a little bit. We compared the thrombogenicity in a swine model where you can connect the jugular vein to the carotid artery and run blood through a Salga tubing, in which these stents, as you see on the bottom, are placed in line, absorb the Osiro, which is a contemporary thin strut DES, and the Magmaris. And you let them run for an hour, and you investigate by immunofluorescent microscopy the number of platelets that adhere to the stent struts. Very simple experiment, very solid experiment. And what you see is when you consistently run this, you find the reduction in thrombogenicity, less platelet aggregation in the Magmaris as compared to Osiro, and more so even to absorb. And this is very consistent throughout a series of runs. Now, In a second experiment, we aim to understand whether the backbone, the magnesium backbone, has any influence on this acute thrombogenicity. So we compared it to an equivalent DES that was made from stainless steel, 316L, had otherwise the same components, and a Magmaris. It was either placed in the middle or flanked on both ends. And you can see exactly same results, same setup, and the results look in that way that Magmaris still shows significant reduction of acute thrombogenicity, especially with regards to platelet aggregation. Now, you can summarize from these results that the geometric design of Magmaris impacts favorably on acute thrombogenicity relative to Absorb and Osyro. There is decreased inflammatory cell attachment in Magmaris relative to Absorb and Osyro, observed after 1 hour in the shunt model. The biolute coating showed reproducible hemocompatibility in various designs, and the backbone material of the magnesium stent obviously has a beneficial effect on acute thrombotic risk. Moving on to late and very late scaffold failure, we obviously learned that there are some other mechanisms important, such as the progression of atherosclerotic disease, which has been termed neoatherosclerosis, because we are referring to progression within the stented segment. And we have observed in previous pathology studies that there seems to be a left shift in drug-eluting stents, owing to the release of antiproliferative drugs that cause leakiness of endothelial cells and earlier rise of neoatherosclerosis. So with this in mind, we had the hypothesis that vascular restoration therapy using the resorbable magnesium stent and reduction of overall plaque burden by statins, which is a very established, clinically well-known therapy, will independently result in decreased neoatherosclerosis progression. Therefore, we aim to investigate the impact of bioresorbable stent implantation using the Magmaris on progression of neoatherosclerosis in a novel animal model that we designed and developed over the years relative to conventional metallic drug-eluting stents. And to investigate the impact of statin treatment, high-dose statin treatment, at least for these animals, on progression of neoatherosclerosis, to be able to compare it to the effect that we see in Magmaris. And finally, to investigate whether incomplete endothelial coverage, the leakiness, results in neoatherosclerosis formation. So this is a busy slide. To make it simple, these animals were randomly assigned to either receive Magmaris or the 316L equivalent drug-eluting stent that I had shown to you before. And now they underwent a series of consecutive experiments, denudation followed by OCT imaging, and then again randomly assigned to either receive statin or no statin placebo treatment, followed by OCT imaging and histopathology as a gold standard. These are the methods that we applied in these animals to really thoroughly look at the underlying disease, what is going on. And what we found is when you carefully look at these sections, slice by slice and quadrant by quadrant, you can come up with a score from 1 to 4, 4 representing the highest grade of neoatherosclerosis and 1 being the lowest grade. You see that there's a significant reduction in neoatherosclerosis formation in the Magmaris relative to its 316L equivalent, an effect that was very comparable to statin effect relative to placebo by histopathology. When we looked by OCT, we consistently found a reduction in macrophages that you know can be recognized by OCT compared to its 316L equivalent. And statin treatment in this particular analysis did not reduce significantly in terms of macrophages because OCT light is limited to the superficial layers and cannot penetrate deep into the tissue. Also what we found, very importantly, is the leakiness of endothelial cell junctions. When you look at the 316L equivalent DES, you can see the leakiness of endothelial cell junctions that give rise to transmigration of lipids and inflammatory cells. This is not seen in the Magmaris, where you have a smooth and tight endothelial layer. Now, with this being said, the main findings are reduction of neointimal macrophages in Magmaris, a decreased formation of neoatherosclerosis over time. We have to take the translational step, and the main objective of the next step would be to look at observational imaging data that are existing. And the objectives here are to characterize atherosclerotic plaque progression between baseline and 3 years follow-up, which is the longest follow-up that we have available right now of Magmaris, and to assess progression of atherosclerosis over time in patients treated with Magmaris. Now, what we've done is we have taken 21 patients in which consecutive high-quality OCT imaging at baseline and at 3 years follow-up was available. We looked at those and put them into 5 equal sectors, the stented segments, as shown on the right side. Every 0.2 millimeter slice in each sector was sampled and investigated. And we also looked at each quadrant, just as we had done for the preclinical study. And what we did is to look for diseased versus non-diseased segments. They are clearly defined by contemporary literature, as shown on the left-hand side at baseline. And we compared it to the 3 years follow-up, where you also have clearly defined literature for homogeneous tissue within the neointimal, heterogeneous or non-homogeneous tissue, and something that we are afraid of, which is possible neoatherosclerosis, meaning progression of atherosclerotic disease. We looked at a total of more than 2,000 frames and more than 8,000 quadrants, both at baseline and at 3 years follow-up. I'm showing you an example of what we had done. This is a patient that had received a Magmaris stent. You can clearly recognize the 5 different sectors that was used to perform easier quadrant analysis in each individual sector. And then you see in green in those pie charts below non-disease segments, and in red you see the disease segments. Now, if we move to the same patients after very thorough co-registration with landmarks at 3 years, you can see in green again, this is homogeneous tissue, which we would call smooth muscle cell rich neointima, healed neointima. We see in orange non-homogeneous quadrants, and in red something that we don't want to see, which is progression of atherosclerosis. So in this particular case, you would see a progression in 3 of the sectors. You would see regression, a reduction of atherosclerotic burden in 1 sector and stable in 1 sector. Now, when you look at the totality of the 21 patients, you can see that overall there seems to be very little progression of atherosclerosis. When you look at the different sectors, the red color is very little, even at 3 years follow-up. There is some non-homogeneous growth of tissue, which we today don't fully understand what this means, but there's very little progression of atherosclerotic burden. And if we break this down on a patient level, and I think this is most important to you, this is what we had done. Everything that goes below the 0 is regression. Everything that is higher in red is progression, defined by the presence, by the increase or decrease in a 5% change in these quadrants with atheroma. You can see that a total of 3 patients up to 3 years had progression of disease. A total of 4 patients had regression, and there were 14 patients that remained stable without progression of disease over the 3 years follow-up. So to summarize, I think Magmaris compares favorably to polymeric BRS with regards to acute thrombogenicity. Magnesium-based scaffolds reduce neointimal macrophages as a sign of early neoatherosclerosis compared to 316L equivalent DES. Magnesium-based scaffolds exhibit greater endothelial integrity as compared to 316L equivalent DES. And finally, 3 years OCT follow-up in 21 patients implanted with Magmaris within the BIOSOLVE-II study shows excellent healing profile and little progression of atherosclerosis over time. With that, of course, we need future studies, randomized trials to confirm this, and I would like to thank you very much.
Thank you, Michael. And again, I encourage you to ask questions through the React. We got one question which respect to the duration of the antiplatelet therapy. And again, we may not be able to comment so much on the 3G versus the 2G, but any comments based on this very encouraging result of repelling platelets? And actually, the second paper was published this month in May in your intervention. Do you think that we can ease on the duration of the APT on the magnesium platform for clinical use?
Very difficult question. I see the point. You would be inclined to say that you may be able to shorten DAPT when you have such a good result with regards to acute thrombogenicity. Now, in the trials, the depth was used just like in any other DES with the current ESC recommendations. I think as long as we don't have clinical evidence in thoroughly investigated prospective trials, we should stick to what we know. However, I also believe that the risk of acute thrombotic occlusion is very low with Magmaris, and that's certainly a good sign for the interventional cardiologist.
And for those of you who don't remember, the BIOSOLVE-IV is 6 months to 12 months based on ACS versus stable patients. Is that what is currently practiced?
Yep.
Another question was, is there a theoretical or practical role for Magmaris for venous grafts? You talk about neoatherosclerosis. There also tends to have some atherosclerosis.
Yes, that is
right?
very good. That's a good point, because they have just in JACC and recently in the Lancet, there are amazing publications regarding the progression of atherosclerotic disease or late failure of drug-eluting stents in venous vein grafts. As a matter of fact, our own group published after 5 years, BMS seemed to perform better than drug-eluting stents in venous vein grafts. So more failures in drug-eluting stents, speaking for the hypothesis that atherosclerosis is picking up late in these devices. And this certainly is an idea. I don't know how it behaves. It should behave well, because usually we deal with soft plaques with a lot of atherosclerotic burden in venous vein grafts, but there's unfortunately no data so far.
Yeah, one of the reasons that we don't have data on that, because the matrix that's available right now is limited to 3.5, and most of those vein grafts are more than 4. So that's probably remains to be seen with 3G. Okay, thank you, Michael. I think now we're going to move to some action. We all like live in the box. And we have Professor Haude and a very interesting case that he did in Neuss, Germany. So stay tuned. With the rules of Live in the Box, we'll stop certain times and we ask questions and we'll have some discussions. So Michael?
Ron, dear colleagues, thank you very much at this later point of the day. Actually, we selected a case that is to some extent quite challenging. When you look at this chart, William has shown to you where to choose or not to choose a Magmaris as the current day. But we want to show you what you can do with the device in a reasonable fashion. So can we start the video?
Welcome to the cath labs of the Lucas Hospital here in Neuss, Germany. My name is Michael Haude. Together I'm here with my colleague Hubertus Degen to share with you a quite interesting case. This is a case of a 70-year-old male patient who presented himself with stable angina class CCS2 in a referral center. He had a profound cardiovascular risk factor profile, including arterial hypertension and hyperlipidemia. He was troponin negative, so no acute coronary syndrome patient, and his current medication included aspirin, statin, and an ACE inhibitor. So the ECG showed sinus rhythm without other abnormalities. On the transthoracic echo, there was a normal LV function with an ejection fraction of 62%, but inferior hyperkinesia. And on the treadmill test at 125 watt, there was ST segment depression and negative T waves in the leads 2, 3, and AVF, and patient presented angina at maximal exercise level. So under these conditions in the referral center, the patient was sent to coronary angiography, and you can see here on this left coronary system there was a focal left circumflex artery stenosis. But mainly on the right system, we saw that there were at least 2 other focal lesions, one proximal and one more subtotal distal before the crux cordis. But in between, there is a lot of diffuse disease, as you can see. Our intention for the circumflex artery now is to do a PCI procedure using the fully resolvable sirolimus-eluting magnesium scaffold, the Magmaris. We're going to do a lesion preparation according to the 4P strategy, implantation of the device, and then post-dilatation using the 4P strategy. And then we're going to have a documentation of the implant result angiographically, and finally also by OCT. This is straightforward, but the question is, Hubertus, the right coronary artery. Right coronary artery has this distal focal stenosis. It has the proximal focal lesion. We did some QCA there, showing that the proximal size there is 3.0 in diameter, distally a little bit less than 3.0. We always know that QCA is undersizing the reality by 1/4 millimeter. So what would be your strategy to address the right coronary artery?
So, well, this is a heavily diseased right coronary artery, but from the angiography alone, the relevant stenosis seem to be very focal. So I would go and treat the lesions very focally.
So Hubertus, this is a strategy to go for. I'm not sure whether this is probably the best one, because it's diffusely diseased artery. Difficult to find the landing zones proximally distally here or there for the scaffold. So I think we first should do something like intravascular ultrasound to gain the best appreciation of the amount of disease and the length of the disease and to identify the most healthy part. And I see a fair chance that we end up with a fully scaffolded vessel segment starting around here and going down to around here, maybe also across the crux cordis here. So this is a quite interesting and also challenging case. So let's move to the cath lab, Hubertus, and let's see what we can do for the patient.
So maybe we can interrupt here and briefly discuss it within the panel, whether you are able to follow our view, how to do that, or would you consider something different?
Michael, based on the chart that we have seen from William and the traffic light chart, there seems to be some problems with calcified lesions, vessels, and also bifurcating lesions. If you look at the crux cordis and you want to also look at it as a disease segment, and if you look at fluoroscopy, there is some calcium visible. To what extent would you allow these a degree or extent of calcification still be feasible for scaffolds?
So with respect to that, I would go, as I mentioned, for intravascular imaging to get a better appreciation about the amount of calcification, whether it's circumferential, whether it is deep or more superficial, and then take my decision. That is why I mention it. The second thing is with the bifurcation down there, if I go for provisional scaffolding, we can go for. If we think that this distal RCA bifurcation stenosis needs a two-device strategy from the beginning on, we would not attempt using a Magmaris.
Do you consider to treat all the lesions or to FFR those who are borderline?
Actually, we had a very, very significant stress test up front in the inferior wall that probably is addressed by both of the lesions in the circumflex as well as in the right coronary artery. So we didn't do an FFR there. That was enough for us to attempt that both of the arteries needs to be treated.
But on the right coronary artery, you have obviously the one that it's very tight at the distal, and then you have also a lesion in the proximal segment. So I don't think that anyone needs to do FFR on the distal one, but what about the proximal one?
You can consider it, yes. But personally, I have to say, is since I need to go in there with intravascular imaging, you will see that with IVUS. Actually, IVUS gives me a lot of information on top of that as well. So I probably can guide my decision there. If at the end it turns out that it's very likely that we have to scaffold almost all the vessel, then the old story of getting more spotted segments based on the FFR measurement is not so valid.
And the other question, IVUS versus FFR, I understand imaging definitely helps you a lot. We talked about the first patient selection and lesion selection, then the sizing, so imaging will help you. It tends to see, I mean, some does claim that OCT will give you a little bit smaller MLD than IVUS. So do you correct for the MLD when you do the OCT? Do you have any preference? Which imaging modality would you use, whether it's going to be IVUS or OCT for this?
So when I personally want to get the full appreciation of the amount of atherosclerosis within the vessel and its full distribution there, my preference is still to go for IVUS. It gives you a lot of different information. It has your virtual histology that gives you even more information on the composition of the plaque, etc., etc. So that is the way I would go for.
Michael, one of the other questions here, and I don't know if the panelists would like to comment on this, is it looks like a long lesion, and obviously a lot of scaffolds or stents would be required. So how is going to be your strategy for the in terms of overlap, and how do you overlap these devices? Amin, do you want to address that?
I think the left circumflex is not an issue. It's very focal. Now the right, if at my center, I would not think of putting multiple scaffolds because of the cost issue as well. And trying to overlap the scaffolds be a bit difficult. So for the right, I think once I get more information from the IVUS, then I will decide my strategy of stenting that rather than using scaffolds for that.
William, is there any nuance of the procedure that you will take here for imaging, for lesion selection?
Yeah, I think the lesions are pretty tight, so I'm not sure that FFR on the right would be necessary. The circumflex you may want to measure. But what this case, a question that this case raises to me is regarding more general strategy. And so without anticipating what might happen, what your decision might be, very often we hear in a case like this multi-vessel that it's either all or none. Either you can do everything with scaffold, and as soon as you have to place one metallic DES in your strategy, sometimes colleagues say, well, it's no use. Well, as a matter, you could also turn it around and say the least vessel encaged down the road, the better. So I don't know whether that is a reasoning that you have with your team once in a while, Michael, or...
No, in general, of course, we don't want to have full metal permanent jacketing. I am not so much aware of having a temporary full metal jacketing using something that is going to disappear after 1 year. A proper thing to important is to appreciate the limited sizes that we have, and you're going to see that, how to manage that then, because clearly on the right side you need more than one scaffold, and how to do that. And one thing is very clear, recommendation is, as it's in the paper, no overlap.
No, William, I was converted on this issue. I was at the beginning thought, well, the whole purpose is to leave nothing behind, right? So if already you put one metallic stand, what's the point? Why should we bother? But as we know, not all lesions risk stenosis also when you put metallic stands. And if you can minimize the overall metallic stands for potential burden later on, then I don't think you should eliminate the option of scaffolding just because you had one vessel that you put a metallic stand. Michael, you want to comment on this?
Yeah, Michael, for now, I think we still try to avoid overlapping the membrane stands as far as possible. Although we know we can do it like side by side, try not to overlap or very minimal overlap. But in this case, I think the circumflex and the very tight RCA lesion can be fixed with one single Magmaris. What do you think of fixing the right tight lesion with one Magmaris and then do an FFR to see if we need to tackle the rest of the lesions?
Is a way to go for, as we mentioned. There are always a lot of strategies. Actually, I took my decision, and you're going to see that after seeing the intravascular imaging. Yeah, and then you probably will get a different view on the amount of disease, because what we would like to do with these devices, we would like to position it from healthy to healthy. And what's to do if you don't find healthy? You see? That's the problem. I think we should continue, otherwise we're running a little bit out of time.
We had a lot of case preparation. Now we can go to the case.
That is good. So can we continue?
The actual angios of that patient, and we started with the right coronary artery where we know it was diffusely diseased, and we were not so much aware of how large the vessel size is distally. Now you can see the angio currently we have done after nitro injection here, and you can see that the distality of the vessel tends to be somewhat significantly larger than anticipated, and that there is probably not a highest grade stenosis at the crux cordis, at least not going to the RPD. There is some kind of constriction of these RAVB, but I think we need to take care of that later on. We do see this subtotal lesion in the pars horizontalis of the right, and then the subtotal eccentric lesion in the proximal part of the right. We will deal with that later on. And now we can go to the other projections that we have made here just to see a little bit better. This is an aerial projection. In general, quite a diffusely diseased artery, some kind of calcification, but not too heavily. Yeah, and then we go to the left coronary artery, and there you see this target lesion in the circumflex artery, eccentric one. Looks more focal here. When we look at the other projections, it tends to be more focal than we have seen it before. The distal part is somewhat diseased, yes, but not high-graded stenosed. So the way how to proceed it, we were going to discuss now. And these are the LAO projections. You can see that there is probably a more focal nature of that circumflex stenosis there. So the general aspect that we're going to do here is we intend to do a Magmaris implantation in that circumflex stenosis. So we wire that. We will do a lesion preparation. We do probably send there a more focal Magmaris. We're going to see whether we can do it with something like 15 millimeter in length to be short, just to cover it there. Do post-dilatation and hopefully get a good result. And then we are done with that and can turn over to the right one, which is a bit more complex in strategy to use there. So now let's start and try to get the wire down there.
So now this is a standard wire that goes to the circumflex artery here. Now we brought down the wire to the distality of this obtuse marginal circumflex area. Now we position the balloon. Can you please inject? Yeah, we go a little bit more there. So good. This is 12. This is the tightest lesion. But my impression is that we need to have probably a longer one than the 15 in order to cover the whole lesion. So please inflate. We go to 14 atmospheres. Okay. Keep it there for 20 seconds. Take it down.
So what's crucial about this predilatation?
Yeah, I think it's important to really see the balloon open, and you can see it's a quite tough lesion. It's opening very, very roughly. Keep it open for 20 seconds. So we're going to see, it's quite important to have a super good lesion preparation before we send in the Magmaris there. Okay, we can take it down. Yeah, you see, we need to have somewhat more work here. Now you can see the balloon tends to be open. It's a little bit bended. But we're going to see whether the 3.0 is good enough here. So, okay, I think we're going to take it down. And then we're going to have a control angio. So can I get some nitro, please?
So what about the sizing of the balloon for the predilatation?
So it should always be a 1-to-1 ratio to the balloon with the artery with the reference vessel diameter. So we suppose here to be in the range of 3 to 3.2, something like that. So that's the reason why. And currently, now let's see what we have achieved here. Attempt is we want to have less than 20% residual stenosis after the predilatation. Okay, you see, we worked quite nicely on the proximal part, but I still believe there is somewhat more work to do. We had not a good result on the more distal part. There is still this eccentric lesion there. So we have to upgrade there, no doubt about that. So my suggestion is let's take a scoring balloon, again a 3.0, in order to improve our dilatation result there. So here comes the scoring balloon. Inject, please. Test. Yeah, somewhat more. Here, test, please. Yeah. So this is 10 millimeter in length. So then we slowly start inflating. With the scoring, that fixes nicely. Usually it's not slipping because of the wires on the balloon. So we go up to 14. So this is 14, and you can see the balloon is working there. So it's a quite fibrotic calcified lesion. You can see some indentation on the right side of the balloon. So we can go to 16.
So what's the issue in using a scoring balloon, even that the non-compliant balloon was fully open in the previous predilatation?
Yeah, I think you see the aspect is that the underlying compliance of the stenosis was not modified significantly by the scoring, by the non-compliant balloon. Actually, this is the reason the scoring is creating a better modification of the underlying plaque and its compliance. So now let's test a little bit, please. Yeah, so that looks somewhat better. Now we go a little bit more proximal. Okay, can you open here again? Because it's extremely important to have a very good lesion preparation, because afterwards, the post-dilatation, it's more than the embedding of the device than really changing the modification of the plaque. So we do several inflations here. So the injury field that we have created here with the 10 millimeter balloon is significantly longer than we initially anticipated, no doubt about that. But I think it's important. The reaction is that we need to take a longer scaffold afterwards. Okay, take down. I think it's quite important. We need to have to do several inflations here along the target area. And then we're going to have a control angio and see what we have achieved now, how much we have improved our pre-dilatation. Okay, now we improved significantly, but I'm not quite sure whether I'm fully satisfied with that. Yeah, I think this is a good one right now, and probably you can see now that we have to go for a longer distance. The question is, did we do enough at this little bend there? So I still think let's go in, do somewhat more lesion preparation in the middle part before we go in there. Probably it has to become, let's see, we have the 10 millimeters length of the scoring balloon to see whether it can accomplish a 20 millimeter long or whether we need to go for the 25. Yep. So let's go back in there. Here we go. Can you test, please? Yeah, somewhat more. Here, test. Yeah. Okay, let's start here. Yeah. Try to go again, 16, 18, something like that. This is extremely important. You have to prepare the lesion along the area where you send the scaffold afterwards. Can you test, please? Yeah. Do one more time here. Now, this is the result that we have achieved. I think we can say that this is probably less than or equal to 20% residual stenosis. I think we need to go in with a longer 25 millimeter 3.0 Magmaris, and then we need to post-dilate it and to taper it, making it significantly bigger probably in the proximal part. So we will probably go up to 3.5, something like there. So let's get the Magmaris now. So now we're going to position the scaffold first in area, and then we switch to LAO to see how it looks like. I think it's fine. It's covering this proximal part there where we dilate it. I think we should not go too much more distal there. And now can we go back to the area? You can see we are nicely after that. So we covered the whole part there. So I think this is correct. So now we bring it in there. We can inflate it as a regular DES, and we go up to 16 atmospheres. Here it goes. So we keep it for 20 seconds. Okay, not too bad. We go to the LAO. Well, not too bad either. So now what is important is that we now need to do the post-dilatation. So I think we should do the post-dilatation first distally with 3.25, and then the proximal part with a short 3.5. So we start with a 20 millimeter 325 non-compliant balloon. Okay, so we can start with the post-dilatation here. We can go up to 15, 16, 18.
Why shall we use non-compliant balloons for the post-dilatation?
Yeah, actually it's important that the balloon opens along its complete longitudinality. The semi-compliant balloons, they open usually not where the tightest lesion was, where the largest plaque burden is, so you don't get this tube-like appearance. Okay, we can take it out. Now, important thing is we're going to remove the balloon right now and then make a control angio before we go with a shorter 12 millimeter 3.5 non-compliant balloon to upgrade the proximal part. Well, that looks not too bad. I think it's nicely open. Still at the side of the tightest lesion, there is some kind of little residual stenosis. We're going to start there with working with the 3.5 balloon, yeah? So let's first go to the area, have a control angio at the area, to have always the pairs available. It's tapering down a little bit distally, but I don't think that is of any value there. So we take that out. Okay. So we're going to start here. So we're a little bit in the middle part there of this 25 millimeter scaffold. Okay, you can take it down. Good. And now we go to the LAO. So my suggestion is we go back to the LAO and make an OCT to see how well opposed and embedded we have the Magmaris, and then we're going to see. It's a good transition there. It's no edge dissection. So now we move forward proximally, rightward side. And we see slowly that the scaffold is probably nicely opposed and also well embedded. There is some kind of protrusion of the plaque through the struts. We have to accept this. Well opposed up here. You can see this is where the largest plaque burden probably was in this little bend there. And although we were in there with a 3.5 balloon at 18 atmospheres, you see we have somewhat like an elliptical shape of the lumen. So it's quite difficult to have this in a round fashion there. So let's continue to go in there. This is the proximal part. It's well opposed there. There we have this little edge dissection proximally. So this is probably what I accept to be there. And if you can go back a little bit on the left side again, more distally there here, you can see this is the strut there, which we have. So what we can try to do is we can try to adapt this part there a little bit more. So suggestion is we go back there and go up to 20 atmospheres just to open it there and to tackle it there. Yeah. So this is now again the 3.5 12 millimeter non-compliant balloon. So again we go to 20.
Okay, so now we control after the post-dilatation again. So it looks fairly good, fairly wide open. So let's see by the OCT whether we have improved it to some extent. Because there we see a proximal third of the scaffold. And now we go proximal, means right side, to see good apposition and embedding. Now we open this proximal part significantly more. You can continue nicely. And then there is this little edge dissection proximally. I'll release that. I'm not aware of that. So can you just go a little bit back and forward on the other direction, going between around 20? Somewhat more, yeah. This little part which is not covered completely by the scaffold, but I don't take care. So we're going to leave it like that. I think we're going to get a good round lumen there, a nice tube. We adapted it in the part where the plug burden is the largest. Actually, it was a little bit difficult to get a very round lumen there, but I think we need to accept this. And well, I think we are done for the circumflex. Yeah. So I think angiographically, I think this is fine what we have achieved. So this was the first lesion, and now we're going to change to the right one. Yeah.
Okay, so that is the end of the first half. We initially thought it would be a quicker one, but if you really follow the 4P strategy and do it really correctly, and also listen to what intravascular imaging is going to tell you, you need to work more on that. And that is a very clear thing. Any comment from the panel?
William, what do you think of the use of IVUS and or OCT for those hospitals who don't have that? Is this something that is really required when you're doing scaffolds?
Yeah, that's a difficult one. We were actually watching the case. It takes a lot of resources, pre-dilatation, post-dilatation imaging, and of course that at this moment is a drawback. Although you'll be able to use these balloons as we move to the right coronary as well. Specifically for imaging, if I'm honest, I would like probably to make a statement that it's hard to contribute now to the field without doing imaging. That's a personal opinion, but I'm willing to stand for that, yeah.
Michael, from the top of your head, do you remember how much imaging was used in BIOSOLVE-IV?
I don't really know, but in our locality, we tend to use more OCTs than IVUS when we come across this scaffold.
I think at my center, recruiting the BIOSOLVE for patients, most of the cases we do OCT because I think we're not very comfortable not using an imaging technique. But I think when it comes to real world usage, this is a problem because not many centers will have imaging in terms of cost, in terms of facilities.
I think we need to move on because I was told only one question, we did three. So
okay, so let's continue to the more exciting
Let's go
part.
to the right.
We had moved to the right coronary artery. We put in a AR2 6-French guiding catheter with side holes that have good support for us, and now we position the wire distally in order to first then do the IVUS. Yeah, again, you see the wire is so obstructing this subtotal occlusion, so we need to pre-dilate there first. So give us a 2 millimeter 2.0 non-compliant balloon, 20 length. So we'll just make a brief dilatation to have a good better flow there, so that the patient can sustain the ischemia a little bit better during the IVUS. So we go a little bit more proximal here. Okay, you can open. Good. Good. Now I think we have now a little bit more time in order to work on the IVUS. Now what we can do is to use the co-registration of the IVUS with the angio to identify certain spots of interest where we would like to know, first of all, the lumen, but also the vessel size according to the EEL, in order to define, first of all, from where to where we have to scaffold, and second, then what length of scaffolds we need to use in order to cover the target length. So this is now the distal cross-section where we have the most healthy part of that completely diffusely diseased vessel. You see we have a lumen area of 2.0 by 2.3 with a cross-section area of 3.7 square millimeters, and the vessel size is, with all the Glago effect that is there,
of 8.7 square millimeters and 3.2 by 3.4. So probably this is a size that could accommodate by IVUS a 3.0 scaffold. So the question then is that our distal landing zone? So we would cover the crux cordis and go then distally. Now when we go to the next bookmark, you can see the vessel is getting bigger according to GLAGO and EEL. Lumen there is the reference lumen we would appreciate is a 2.8 by 2.9, 6.4 square millimeter lumen, which by itself is of course enough, but this is not the angiographically stenosed area. And then if we continue to go there, we go through the stenosed area, which we pre-dilated with a 2.0 balloon, to the proximal part, which is the most healthier part there, which has a 3.0 by 3.2 lumen there. So my suggestion is to anticipate to scaffold the whole length from the very distal part to that area there. And now we continue to the more proximal part to look at this angiographically intermediate sized stenosis. When we look by IVUS, it's 2.6 by 2.9. So probably this is good enough and doesn't need any kind of treatment. And if we go then more proximal, next one please, you see we are going to these tighter lesions there. It's 2.0 by 2.3. The reference vessel area is 13.1, but the reference diameter is 3.9 by 4.3 according to the GLAGO effect of the EL. So something like 3.5 probably will be good. And if we go to the tight eccentric stenosis there, you can see 1.8 by 2.1 and still something around EL 4.0 by 4.3, but something that we can open up in the direction of 3.75 in this area would be good. And then we go to this target area distal, proximal to the band, and you can see is that the lumen there is fairly good, 2.7 by 3.4. So Robertus, I don't think that we need to touch this area there. We were suspicious to do that when we saw the angio to start immediately after the guiding catheter, but with this IVUS image, I would say we can leave it and just start proximal to the band and then go down there. And then we did a length measurement according to that. And can we see that length measurement, please? Now, if you're going to see right now the distance that we measured for that scaffold length that I would anticipate to use here, probably the 25 millimeter Magmaris, we have some space in there. So we measured from proximal to distal targets sides 23.2 millimeters. So we have another approximately 2 millimeters of space. So I think this is the way to go for to cover that. And then we need probably to measure from this very distal bookmark where the vessel was most healthy to that proximal part, to the third bookmark. You can continue to the next one. So exactly here, somewhat more. So we have here about 42 millimeters. So probably it will end up with a 25 and 20 millimeter in length to cover this whole lesion. So I think we got significant information in order to schedule our procedure. When we look at the dimensions we have here, I think what we need to do is we need to go to something like a prepare lesion with a 3.0, 3.25, distally 3.0, proximally maybe a little bit more 3.5 for that part there, the other part 3.5 indeed, and then put in there approximately distal, the first distal one a 3.0, and then connected a 3.5 for this area there, and for the proximal area go for a 3.5. Good. So then let's start with the lesion preparation. Okay, so roughly to summarize, I think the intravascular imaging really helped us to develop a strategy, at least from my point of view, which goes away from a focal scenario, going more to a scenario going from most healthy to most healthy. Yeah.
I mean, what would you do in your practice? Would you, based on what you've seen, you would cover everything, or you'll still just treat the focal lesion?
I think during the IVUS pictures, if you could do an FFR, if you are going to cover just the distal part with the scaffold and then do an FFR, and if that's fine, I think I would just leave it at that. But putting two scaffolds side by side, I don't think I'm that comfortable. And the other thing, the markers on the scaffolds is sometimes very difficult to identify on fluoroscopy. You have to have change to different angles and to get exactly where. So it's not so easy to put it side by side.
Yeah, I think that's what you're going to show us in your case. I just want to say that if you're not comfortable with that, you have two options, either to do this just with drug-eluting stent, or just to treat with focal and then see how you're doing. Because this vessel is diffusely diseased. Any way that you're going to do something is going to look not optimal.
Yeah.
And I think you don't want to reconstruct the entire vessel right now, even with scaffolds. So the question is, when do you stop? And there is some risk here. You are going to do it across the PDA. So there are complexities. So I think, why don't we see it? If we'll have more time, we'll discuss after the...
You're going to see what is going to happen.
Yeah, I'm sure it's going to be interesting.
Can we continue?
Slowly. This is 30 by 20. We go up to 12 atmospheres, not to dissect too much. Okay, take it down. 12. Take it down. Open. Not too bad. So I think what we need to do is we need to improve to some extent with the 3.5 in these pars horizontalis, where the larger plug burden was, and the vessel is somewhat bigger, and then also predilate in this proximal area there. So, okay, so we manipulated the wire down in this PDA, so we can keep that there for protection. Then we go to predilate with the 3.5 non-compliant balloon. So let's start about here, just before the crooks. So this is 20 in length. We go to 16, 18. Next one. Again, 18. So this is our proximal landing zone for the 3.5. I think this is, by size, fairly good. And then when we go to the proximal lesion site, we're going to start here. Yeah, and the device detection, you can see that in the middle part, the balloon is not fully open. Maybe we're going to need a scoring balloon 3.5 there as well. Yeah. So now we go up. 14, 16. Let it work a little bit. We can open here. Yeah, we can go to 16 again as well. Yeah, I think it's important to here. We need to have 1 or 2 dilatations in order to really change the compliance at this entry part of that segment there, immediately after the bend where the high-grade stenosis was. So take it down. So this is now the control after the scoring. And I think we did something good. We can see that we have dissected the artery in the pars horizontalis, which is okay. I think the ostial part of the side branch there is okay. We keep the wire in there, see what is going to happen. And we start now scaffolding with the 3.0. From distal, we start with the 3.0 20, because we had measured about around 45 millimeters. So we start with the 3.0 20, then upgrade this with a 3.5 in the pars before the crux cordis, and then connect the 3.5 to that. So just to show how nicely it goes down there. Let's test, please. Yeah, I think this is a good spot to start with here. Yeah. So you open up. We go to 16 atmospheres again. Continuous inflation. Here it comes. So that we keep it for 20 seconds.
You can nicely see the tapering between the distal right coronary artery and the proximal PLD.
Yeah. I agree, but still I think we need to work on it because we were there with the 3.5 balloon, so need some more. Can go down. Good, that's not too bad. Consider the side branch there, but I think this is okay. So the next most important thing right now is let's do first the post-dilatation. Do the post-dilatation. I think 3.0 is fine there with the short 12 millimeter 3.0, and then try to go proximally with the 3.5 and then dock the 3.5. Take it down, inject. Yeah, that's fine. I think exactly we positioned the 3.5 balloon now for pod procedure, and we jail this other wire there. So now we can open here.
Have you ever seen any trouble with a jailed wire in Magmaris?
Not so far. I mean, afterwards you have to gently try to pull it out. If there's any kind of resistance, you need to support it. We will do that in a general way. Once we finish down there, we will take it off before we will treat with the proximal part. I think the side branch for me is okay. The transition to the distal part of the RPD, it looks a little bit stenotic, but probably it's related also to some kind of spasm. We're gonna see that, what we need to do there, or if we need to do something afterwards. So now, next thing is to continue with the 25 millimeter 3.5 to connect it to the first one. So we want to not to have an overlap there. We want to get it adjacent to each other. So that's the next point. So the next thing is now, before we bring in the second Magmaris, is since the side branch is not obstructed and flow is good in there, we will retract the second wire there. You can see it nicely goes along these Magmaris. That's fine. Okay. It nicely slips in there. And now we need to find our right spot so we can connect already. So we don't want to have overlap. We want to have the scaffolds next to each other. So ideally we position the distal marker of the delivery device of that Magmaris here to the proximal tantalum marker of the implanted device, of the implanted Magmaris. So now try to find it. This is exactly where we like to go. Good. So now, open. We go in to 18. Keep it there. 2. Okay, take it down. So now we're going to post-dilate the second Magmaris with a 3.5 non-compliant balloon. So you can open. Okay, we go to 18.
Yeah.
So, okay. Again, go to 18. So that's not too bad. I think we oversized a little bit this distal part. But again, watch now what is happening to the distal part of the right corner. It's improving.
Yeah, now that we gave nitro,
yes.
it was spasm.
Yes, this was some kind of spasm according to the wire. I think this is fine. Now, the major question right now is, let's continue with the decision we took in order to go with the 25, 3.5 to that proximal part to cover it. Yeah, I think this is fine. This is exactly fine. Here we want to go. Good. So now we open, go to 18 atmospheres. Yeah. Good, and keep it at 18. So we had distally a 3.0 Magmaris in there, distally post-dilated with the 3.0, proximal to the 3.5. Then we brought a 3.5 proximal to that, edge to edge. We post-dilated with the 3.5. And now we did the 3.5 Magmaris proximally, so we're going to post-dilate this one with a 3.75 to enlarge it a little bit, especially in this proximal segment there. So this is a 3.75 millimeter, 20 millimeter in length, non-compliant balloon. We go to 18 atmospheres. Good, so you can open it, 18 atmospheres. Here we are, exactly. Pushes outside, we go to 18.
18.
Good.
Want to give nitro again?
Yeah, we can give nitro. So, next step is now we had the post-dilatation. We do the OCT control. We go to the other projection. Now this is the second pullback now, where we see both the transition of the distally implanted scaffolds, the 3.5, to the proximal 3.5. Now we go on the very right side, left side, distally, starting at around 5. So now this is, we do it very slowly. This is the proximal part of the distal 3.5 Magmaris. You can see we achieved a nice round lumen. We have probably a good apposition of the scaffold struts here. So can you continue to go proximally? Yes, exactly, slowly, slowly, slowly. So we can see it here. It's still fine. You can continue. Yeah, I think this is a good result. Still round lumen here, good apposition. Super. So that's a transition. Maybe you can start here, and then we are in the so-called normal vessel here. So this is a 2.5 by 3 vessel. We have a lumen area of 5.5 here. So that is probably fine. And then we go more proximally. We see that there is a dissection here. You can see a significant dissection.
The lumen is fine, but the dissection is significant. So, and then we come to the scaffold here in the part, the proximal part. And we can see, you can continue, that we achieved here also around lumen with mostly good position and embedding. Distally it could be a little bit better, although we had a 375 in there. Yeah, we have round lumen here, this is fine. And then we go proximally. Yeah, and then we have the smash there, or the residual slots are there. So the question right now is what to do with the residual part between the proximal and distal scaffold. So what we can do is we can measure the length, which is there exactly here. So this is exactly at 15, and then we go to the start of the other one. So we then need to go in there. You need to continue 15 to 30. Here, stop here. So it's around. It's here. This is strutting. So it's around again. It's 15 millimeters there. So now when we look by OCT, and if you go back into the dissection, whether we would like to leave something like that or not, probably we have to say we don't want to leave it like that. Although we have to say we didn't predilate the lesion there. So maybe it's just because the dissection went from proximal to distal, but in any way, I don't think I want to leave it there. So what does it mean? We need to try to bring in another 15 millimeter 3.5 in there post-dilated. But now the important thing is we haven't correctly pre-dilated the lesion. So we need to go first in there with a 3.5 balloon to open it up correctly, although it is dissected there, but I think we need to do so. And then we put in a 15 millimeter by 3.5, post-dilated with a 3.75, and then probably we should have done it. Okay? Yeah. So yeah, you can open here. Good. Yeah. Good.
20.
Good. So open here again.
Yeah. Okay.
Good. Okay. Okay, so we open. Yeah. We go to 18. Okay, this is now the 375 non-compliant balloon. We go up to 20 atmospheres. 20.
Yeah.
We can see here the layers of the scaffold, which are nicely opposed and embedded. Yeah, we can continue. And then we probably managed to get the 15 millimeter scaffold exactly in between. So there was no real overlap there. So here's a little side branch, yes. And then there is again, here is the potential, here's a little overlap. You can see it. Here is some kind of overlap there. You see it at between 7 o'clock and 8 o'clock on that side. Very little. Continue, please. And then it's going to disappear already. So it's about 2 millimeters of overlap, which we have to accept. The lumen is wide open. So then we go to the proximal part. Again, here was that little overlap. Can you go like a little bit more distally? Here, yeah. That was where the section was. Continue, yeah, and here's that gap. Little gap is there, a millimeter or so. But here is some kind of malapposition of the struts. Here, at that point. So that is this part there. Probably we will go back there with the balloon and go to somewhat higher pressure, but I think then we are done. So can you go now proximally? Okay, so we need to go here. And open it, please. So we go to 18 atmospheres. So now actually we're going to see what we have gained there. This is the control angio after all the work we have done. Well, not too bad. Not too bad. So what I'm going to do is I take out the wire, give some more nitro. We do then one without wire. Well, that's not too bad. So let's go to the area 75. Well, that's not too bad, isn't it? Side branches are all open. Good. So now I think it was a long way to go, but if I sum up, actually the circumflex artery was probably a little bit straightforward. Magmaris implantation according to the 4P strategy with, I think, a good documentation of the final result. Here with the right coronary artery, we can go back to the LAO. Can we go back one more time because it gets a better appreciation of what we have achieved. I think we need the help of the additional intravascular imaging. I think I was told us where we need to start with our scaffolding and where to stop. Well, I personally had the hope that we can leave this gap between the two segments that we scaffolded free of scaffold. Unfortunately, we saw in the OCT that there was a clear significant dissection, so we need to tackle that. We were able to show that we were almost get it adjacent to each other. There was only a very little kind of superposition of the scaffolds there. We post-dilated significantly there so that this is minimalized the luminal loss that we have due to this overlapping thing there. Well, I think the proximal part, proximal to the scaffold area, I think angiographically this is so fine that we can leave it. We knew from the initial IVUS that it is fine. The distal part of the right coronary artery looks intermediately narrowed, but I think for all the story we have there, it's fine. You can appreciate that the distal scaffold is overlapping the side branch, so no obstruction of the side branch. We are not aware of the struts hanging in front of the side branch. We know they disappear over time, so that is something which we have to accept. So we're going to put this patient on 1-year DAPT, and hopefully we gain quite a lot of him, because at least for the right coronary artery, this is now fully scaffolded with absorbable devices. Otherwise, it would have been full metal jacketed, and I think that will benefit for the patient on the long-term run. So also on behalf of Hubertus and Diana, I would like to thank you.
Very nice result.
Michael, in the interest of time, we are running a little bit late, but we'll give you the floor for one additional question. We have a session with the 3 M's, the 3 Michaels. We have the session of the 4 P's, but there's also the 3 C's, which is complexity, contrast load, and cost. One philosophical answer, please.
So if you want to ask me the amount of contrast we have used, it was around 200 ml. If you want to ask me about the additional cost for the imaging, the OCT was for teaching purposes and documentation. IVUS I would have chosen. If I would have controlled the eye with IVUS, the dissection in the right coronary artery, I would nicely have seen it, especially when I use the chroma flow system. So I don't need the OCT necessarily on that. So if you want to do it properly, that is the important thing. At this time, you should not spare. If you need to spare, don't use scaffolds.
Was there any difficulty to pass the Magmaris in any of those lesions, the proximal or through the struts? It was flying through.
And you can appreciate to the PDA osteal lesion how it looks at the end after doing the pod procedure, etc. It was fairly fine. Good flow in there, so we didn't do anything on that.
No, thank you very much.
Thank you.
So we move to the last presentation of this symposium. It's going to be given by Michael Lee, and this is going to be a snapshot to BIOSOLVE-IV. This is the large registry post-marketing that is being conducted now.
Thank you. So this is about the new clinical insights from the BIOSOLVE-IV registry. I have no conflicts of interest to declare. So the registry actually is a prospective multi-center real-world registry. The primary endpoint is target lesion failure at 12 months. And there are a number of secondary endpoints at a time point of 6 months and then 1 to 5 years, which include TLF, clinically driven TLR, and target vessel revascularization, cardiac death, target vessel MI, scaffold thrombosis, and procedure and device success. We have 2 coordinating investigators, Stefan overseeing Europe and myself overseeing Asia-Pacific region. So altogether, we recruit 1,065 subjects with de novo coronary artery stenosis. So we follow up the patient 6 months and then every year until 5 years. We have 90 sites in 23 countries, so mainly over Europe and Asia-Pacific region. The subjects were enrolled according to a consensus letter that we sent to all the investigators, mainly to stress on the 4P instructions and then to follow the instruction for use requirements of the Magmaris stent. One point to note is that about 14.5% of all the patients recruited in the BIOSOLVE-IV registry was actually having non-ST elevation myocardial infarction. I have to stress the 4 Ps again because it is the single most important point when we implant this Magmaris scaffold. So patient and lesion selection, proper scaffold sizing, and then pre-dilatation followed by post-dilatation is the most important points to deliver. So we have the first 200 patients data available, both at 6-month follow-up and 12-month follow-up. At 12-month follow-up, 97% of the subjects were still recruited. There was one death at 12 months, which is non-cardiac death due to cancer. Baseline characteristics, this is a real-world registry. It is a real-world patient, and you can see mean age 62 with slight male predominance. Over 50% of these patients are having the hypertension, hyperlipidemia, and they're smokers. Diabetes, about 22%. And non-ST elevation MI, I mentioned 14.5%. Majority of the lesions are located in the LAD, and the average lesion length was 14.5 with a mean diameter of 3.3. Although we suggest the use in the B1 or type A lesions, there has also been a significant proportion of B2 and type C lesions, 17.3%, and 6.5% with at least moderate calcification. This is real-world data. And at 6 months, the target lesion failure rate was 2.5%, and at 12 months, it was 4.6%. Very, very comparable to the previous BIOSOLVE trials as well as the DES trials. So if we look at the each category, we have no cardiac death. There was 1 target vessel myocardial infarction, and then 5 critically driven target lesion revascularization. No CABG. The instance of definite or probable stent thrombosis rate was 1 at 6 months. Which is actually the same patient as target vessel MI. This was a patient, which I will elaborate on, who presented with non-ST elevation MI. And then the index procedure was done about 5 days after this non-ST elevation MI in a heavily calcified RCA with Magmaris stent. And then actually the patient was planned to have mid-capped a hybrid procedure done about 5 days after the implantation of Magmaris. So DAPT was interrupted 1 day after implantation of the Magmaris stent, and then the patient developed scaffold thrombosis and target vessel myocardial infarction 5 days after after the mid-cap procedure. And then the patient subsequently received stage procedure to the left circumflex about 10 days later with the treatment with a DES. So this was the only case of scaffold thrombosis because of the interruption of DAPT. So if we put things into perspective, you compare the BIOSOLVE-IV registry data with the BIOSOLVE-II and III, you can see very comparable 6-month TLF rate of 3.3% with BIOSOLVE-II and III, and BIOSOLVE-IV 2.5%, at the 12 months, 3.3% versus 4.6%. And then scaffold thrombosis, definite or probable, there was no patient observed in the BIOSOLVE-II and III, and only 1 patient in BIOSOLVE-IV that I mentioned before due to the stopping of the DAPT. So our plan is to extend the BIOSOLVE-IV registry even further to include 1,000 more patients to further confirm the safety and efficacy of the Magmaris stent. So altogether, we are going to recruit 2,065 subjects with de novo coronary artery lesions and with the same clinical follow-up and the same endpoints. So to conclude, the target lesion failure rate at 6 months and 12 months was respectively 2.5% and 4.6% in this BIOSOLVE-IV registry, the first 200 patients, which actually confirmed the TLF rates of BIOSOLVE-II and BIOSOLVE-III studies. And again, the results are comparable to various second-generation drug-eluting stents. The Magmaris stent has shown excellent safety profile up to 12 months with no cardiac death, and only 1 patient had target vessel myocardial infarction and scaffold thrombosis due to the interruption of the DAPT. Thank you for your attention.
Thank you, Michael. And Ron will conclude the session.
So first of all, I'd like to thank Biotronic for sponsoring the session and all the participants. What have we learned and what are the take-home message? Vascular therapy is the holy grail of scaffolds. We still believe that there is a merit to look for vascular restoration, as was presented by Dr. Worms. Magmaris seems to satisfy the three main pillars of vascular restoration therapy. Magmaris seems to have a beneficial effect on the risk of acute thrombosis and in the reduction of neoatherosclerosis. We learned about the 4 Ps, that they remain essential in achieving optimal results with Magmaris. And there is a new clinical data from BIOSOLVE-IV, which is promising and comparable to the second-generation DES performance. I think we should recognize that we have been evidence to a very interesting case that shows that the boundaries can be slightly expanded, although I would say this is only for advanced individuals like Michael Haude, because there are very few that would do it in a very meticulous way that he does the cases. I was watching, he's not satisfied with just balloon dilatation or post-balloon dilatation. He looked for optimization. So if you follow that, I think you're going to get good results. And we're all waiting for the next generation of resorbable magnesium scaffold, which is currently in development, and hopefully we'll start to see them, at least in trials, in 2019. So I would like to thank everybody for participation, and for those of you who stayed to the last moment, thank you and enjoy the rest of the evening.